Welcome to the lecture on renal failure. This is Module 4. So we're going to start out with a comparison of acute kidney injury, or AKI, versus chronic kidney disease. And there's some important distinctions between the two. Of course, the onset, acute kidney injury, as you would expect, is a quick onset. A chronic kidney disease is going to happen over time. Most common cause of acute kidney injury is acute tubular necrosis. So you get damage to those tubule cells in your kidneys, which can cause that acute kidney failure. And the tubules are the tiny ducts in the kidneys that help to filter the blood as it passes through the kidney. So those little ducts get injured. But with chronic kidney disease, as you would expect, a chronic issue. So diabetes is the most common cause of that. Diagnostic criteria is different. It has to do with acute kidney injury for a reduction in urine output, and or we have a bump in that creatinine level. So as you'd expect, BUN and creatinine are going to be important labs for us. When we start talking chronic kidney disease, we start measuring it in a GFR, glomerular filtration rate of less than 60. Okay, and it has to be over time, so greater than 3 months, or we've had this kidney damage for greater than 3 months. Acute kidney injury is reversible. Chronic kidney disease is irreversible and progressively worse. And then the thing that kills people with acute kidney injury is infection. And then chronic kidney disease, it's more like cardiovascular disease. So yeah, some important distinction between the two of those. So let's talk about acute kidney injury. So we can have anywhere from slight impairment to severe impairment. And its characteristic is this rapid loss of kidney function with this bump in the creatinine, and or we have a reduction in urine output. You do have an elevation in the BUN and the potassium level, which will be important. Potassium is also really important when we talk about renal failure. And then azotemia, which you get this accumulation of nitrogen waste, and we start having some problems from that collection of the waste products. And it does have a mortality rate, even though it is reversible. It is something that needs to get figured out pretty quick because it can mess you up when you have all of these things going wrong. And remember, we talked about high potassium levels and how dangerous they can be. And when you have this buildup of potassium, you also have a buildup of acid. And this inability to do any of the buffers that we do with the kidneys. And so we get some acid-base imbalance problems. So yeah, acute kidney injury is not something to play with because it can kill you. All right, so let's talk about causes of acute kidney injury. So you've got pre-renal, intrarenal, and post-renal. So pre-renal, it's something that happens before the kidneys. So when we were talking about heart failure and we were talking about its impact on the renal system, this is pre-renal. So it's before the kidneys that the problem occurs. So the problem with heart failure is you're not getting good blood flow to the kidneys, and that would be your cause of your injury. So not good perfusion. Intrarenal means it's a problem with inside the kidney itself. And then post-renal is you can't get stuff out of the kidney, so there's a blockage below. So that would be, we're going to talk about in detail all of these different causes. Okay, so we have somebody named JK. Actually, let's go back for 1 second because I thought I had another slide, but I don't. So let's go through this real quick. So pre-renal, we talked about cardiac output. Okay, so also dehydration would be another thing where you have just like low blood flow because you're dehydrated, so there's just not as much blood. And then intrarenal, so direct damage to the kidney. So if you have prolonged ischemia, so after you've had pre-renal failure for a while, then you can have some intrarenal damage because you're not getting those cells perfused, right? Nephrotoxins can also cause damage to the kidney tissue itself, so things like contrast medium. So that's why we ask people if they're allergic to contrast dye. Hemolytic transfusion reactions can cause this, so please remember this in the future when we talk about anemia. This is part of the problem. You check for blood in the urine because that's telling you that you're having damage to the kidney itself. So hemolytic transfusion reactions. Crush injuries can cause this too. your kidneys just get plugged up with all the damaged cells. Also things like lead and arsenic. And then kidney diseases like acute glomerulonephritis, and then lupus, and then acute tubular necrosis. So we talked about that being the most common cause of acute renal failure. So there you go. We talked about that. So acute tubular necrosis is the most common cause. It results from ischemia. This severe ischemia causes disruption in the membranes and this destruction of the tissue. It's reversible. It can happen with people who have major surgeries, shock, sepsis, acute muscle injury from trauma, prolonged hypotension, sorry. And then post-renal things would be like a mechanical obstruction of outflow. So that would be like BPH or prostate cancer, or if you've got kidney stones or some kind of trauma or some kind of tumor, something that's blocking the ability for the urine to get out. So it backs up into the kidneys and causes problems. All right, now we're going to talk about GAK for real. A 37-year-old man fell off the roof. He can sustain severe lacerations to his face and left leg with substantial blood loss. So which kind of kidney injury would you expect he would have? So the key word here is substantial blood loss, right? So maybe some hypotension. So we would say he had pre-renal. What are the contributing factors for this? So the fluid volume loss, just because of the blood loss. Signs and symptoms of renal involvement, what would we look for? So signs of fluid volume loss, right? So we have decreased cardiac output, which leads to decreased renal perfusion. And then we're going to look here at clinical manifestations. So let's go to the next slide. So main one is decreased urine output, okay? So oliguria, so it's defined as urinary output that's less than 400 mils a day. That's important for you to know. Oliguria, less than 400 mils in a day of urinary output. How does hypovolemia contribute to acute renal failure? So the decreased urine output leads to, hypovolemia can exacerbate this acute kidney injury, okay? And then signs and symptoms of decreased urine output that cause fluid overload. So neck veins distended, bounding pulse, edema, hypertension. So all signs of fluid volume overload, right? That can lead to heart failure, pulmonary edema, pericardial, and pleural effusion. So all problems that you have whenever you have fluid overload. So it kind of just depends. You've got two possible causes. Is it a heart problem or is it a kidney problem that leads to the fluid overload, right? Okay. Also, remember we talked about acid-base imbalance. So your kidney can't excrete hydrogen ions or acid products of metabolism. So you get this buildup of acids, right? So that leads to metabolic acidosis. And then go back to that and think about signs and symptoms of metabolic acidosis. Sodium imbalance. So we have this problem with serum bicarbonate production. We have increased excretion of sodiums, which leads to hyponatremia. And then we have too much potassium, okay, which leads to this impaired, because of the impaired ability of the kidney to excrete potassium. And then the sign of potassium excess is EKG changes. Okay, going back to metabolic acidosis, sorry. So serum bicarbonate production is decreased, right? So reabsorption of regeneration is defective. And then we have severe acidosis that develops. So remember, with a severe acidosis, you're going to try to blow off some extra CO2, which leads to Kussmaul's respirations, right? Deep and rapid. With the sodium imbalance, they can have cerebral edema because of that hyponatremia. So neuro changes would be a primary thing you'd look for that. The EKG changes with potassium excess are things like peaked TIVs, widened QRSs, and ST depression. So can kind of show up as a cardiac problem with that ST depression. So important to draw labs when you're trying to roll out MIs. All right. So hematologic disorders, they can get leukocytosis, so not enough white blood cells, and that can cause a fatal infection. Usually it's a urinary or respiratory infection. And remember, that's the most common cause of death. So whenever you've got somebody with renal failure, you're going to want to make sure that they don't have any problems with their urinary or respiratory systems. And then waste product accumulation, so increased BUN and creatinine. So that's what that's about. Neurologic changes, so we can have fatigue, difficulty concentrating, they can have seizures, stupor, and coma. So some significant neurologic changes. All right, so JK's injuries have been repaired, but his urine output has dropped below 350. So what is that called? Do you remember? Oliguria, right? JK's lab results reveal a BUN of 53 and a creatinine of 2.7. Are his levels normal? Of course, as you would expect, they are not normal. He reports being fatigued and his blood pressure has risen to 178/98. Why is this? So remember, one of the complications is fluid overload, which can cause hypertension. Our friend JK should have stayed off the roof. What other things would you look for? So he's in that oliguric stage of prerenal acute kidney injury. So think about what other things we would look for. What other lab tests would we look at? And then his urine output suddenly increases to 2 liters overnight. Is this a positive sign? So that just means that he's gone to the diuretic phase. So the urine output can be anywhere from 1 to 3 liters, maybe up to 5, because the tubules can't concentrate the urine, okay? So the kidneys can excrete, but can't concentrate. So you can have some complications of this stage, so really have to monitor that patient. So his urinalysis reveals slight hematuria and low specific gravity. His renal ultrasound findings are normal. So what's the overall goal in the management of JK at this point? So basically, we want to keep his signs and symptoms in check and prevent any complications. What other nursing interventions would you implement? So we would look to treat the cause, whatever that happens to be. In his case, it's anemia, right? Fluid volume loss. So we'd want to treat both of those, manage those signs and symptoms, and then just make sure that we're preventing complications. All right, interprofessional care. So again, eliminate cause, manage signs and symptoms, prevent complications. And then we want to ensure that we've got good intravascular volume and cardiac output. So between loop diuretics and osmotic diuretics, we're going to closely monitor I's and O's during that oligurics phase. Fluid restriction calculation, so all fluid losses for the previous 24 hours plus 600, and then we want to watch that potassium level. Hyperkalemia is one of the most serious complications of acute kidney injury because it can cause those dysrhythmias, so we want to make sure that we keep our potassium in check. All right, with everything we talked about, you're always going to need to know about nutrition. So making sure we have adequate calories. We want to restrict sodium, potassium, and phosphate in these patients. Calcium supplements might be necessary. Phosphate binding agents might also be necessary. So we want to make sure that we have primarily carbohydrates and high fat, and adequate protein to prevent breakdown. All right, so JK continues to improve, but he lost 6 pounds since admission. He expressed concern about maintaining muscle mass and his ability to perform his job as a construction worker after discharge. So do remember that your patients have whole lives, and we need to keep those things in mind whenever we're talking about discharge. Ask them what they do for work. Um, See if they've got any ability to do some like modified duty or something like that, if that's something that you need to get a note from the provider for them. Think about those things because they're real concerns that the patients have. All right, management of these guys. So vital signs, which makes sense, right? Daily weights, strict eyes and nose, check the urine, general appearance. And if they do have a dialysis site, you would want to assess that. Mental status, level of consciousness, right? Remember we talked about cerebral edema, so we want to make sure that they are neurologically intact. Oral mucosa, is it dry? Lung sounds, are they fluid volume overloaded with crackles? What's their heart rhythm? So they are going to be on a heart monitor, right? Because of that hyperkalemia. And then other labs, BUN, creatinine. For this guy, he would get CBC. They would do electrolytes, and then any diagnostic testing, like a renal ultrasound or something like that. Health promotion is kind of the same thing. Daily weight, eyes and nose. Replace any significant losses. Diuretic therapy for fluid overload. Avoid nephrotoxic things. So we aren't going to do a CT scan with contrast on these folks, okay? They're already compromised with their renal function, and that would just kind of push them over the edge. Aseptic technique, that's what I wanted to point it out here because of that risk for infection, remember, because they can have leukocytosis. And then skincare, mouth care, those sorts of things, because you're going to have all these shifts in fluid. So JK progresses well and is preparing for discharge. His BUN is 19, serum creatinine is 1.4, and urinalysis is normal. He's gained 2 pounds since his nutritional needs were met. So good job. All right, so gerontological considerations. So with our folks that are a little bit older, just naturally you have decreased GFR with aging, and they're more susceptible to acute kidney injury because things like dehydration, because of multiple medications that they might be on, between diuretics, laxatives, those sorts of things. Illness and immobility can also contribute to dehydration. Hypotension, if they've got any obstructive disorders, if they've had surgery or infections. They do have a decreased ability to just recover naturally. They just don't heal as fast. And then renal replacement therapy could still be an option. So that would be some sort of dialysis. Okay, so chronic kidney disease. So it's progressive, it's irreversible. So as soon as you've lost function, it's gone. It's more common than acute kidney injury. More common because of the change in population. Everybody's getting older. We have more obese folks. We have more diabetes and hypertension. Over 500,000 Americans are receiving treatment for end-stage renal disease, which is just a staggering number. And it does have a high mortality rate. So leading causes, again, are diabetes. So definitely something to do some education on your folks with diabetes about kidney disease. and hypertension would be the second most common. Other things like glomerulonephritis, cystic diseases, urologic diseases. Usually they're asymptomatic, which is the scary part, until um, they're really far gone. And then it's very underdiagnosed and very undertreated. So these are our definitions of GFR versus what we do about it. So stage 1 kidney disease is just the diagnosis phase. We're going to reduce risks. Progression is very slow at this time. And then we go in through these stages. Important that's 3A and 3B. We have to start getting more aggressive when we start getting 3B. 4, we're getting ready to do some sort of dialysis or a transplant. And then stage 5, we have to do some sort of renal replacement therapy, so some sort of dialysis at this point because it's incompatible with life. This is table 46.7 from your book, so spend some time getting familiar with that. We're going to introduce our new friend KW. 35-year-old man began to notice weakness with activities such as walking distances or running. He had tingling over his body, particularly in his hands and feet. 35 is not very old. Okay, so at age 5, KW was admitted to the hospital for hematuria and acute glomerulonephritis was diagnosed. Remember, this is a risk factor. At age 11, he was admitted to the same hospital with recurring acute glomerulonephritis. He's had no follow-up until this admission. Whew, gracious. This is a money picture. You've got a couple of different pictures like this throughout your book for various conditions. There's a great one on sickle cell that we'll see here in a couple weeks, but this is your one for chronic renal disease. So it affects almost every body system. So spend some time getting familiar with this. Whenever your kidneys are having problems, you can have problems everywhere. Neurologic, GI, endocrine, metabolic, hematologic, neuropathy, musculoskeletal issues, skin issues, pulmonary issues, vision. They can have vision loss, actually. So some pretty significant issues. So spend some time getting familiar with this. Very helpful to know all of these things. Oh, so KW says he has an increase in urine production several months ago and was concerned about the possibility of diabetes. His history reveals a grandmother and aunt have diabetes, no family history of renal disease. He states that he's recently developed a severe decrease in urine output, as you would expect, because this is a renal one. Okay, so early on, we don't have any changes in urine output, okay? Polyuria may be present, but it's more related to diabetes. As it progresses, we get increased fluid retention, and they will need a diuretic. After a period on dialysis, patient may become anuric, so they don't make any urine. So you get to this point where you have this waste product accumulation. So as your GFR decreases, your BUN and creatinine rise. The BUN level rises because of the kidney failure and protein intake. It can cause things like fever, nausea, vomiting, lethargy, fatigue, impaired thought processes, headache. Okay. As your GFR goes down, BUN and creatinine go up. So serum creatinine clearance is the most accurate indicator, okay? So these are his labs. So potassium of 6, is that normal? And then you've got elevated BUN and creatinine. Hemoglobin and hematocrit are also very low. So he's got some anemia happening. Remember, there's issues with erythropoietin. So that's the ability to make some red blood cells. And so anemia can be a significant problem for these folks, okay? So he states that he has difficulty with itchy skin, assumed it was related to some winter skin dryness. He recently received a diagnosis of restless legs. He's undergone a renal biopsy, which shows severe damage of his nephrons. He is hypertensive. He's got chronic glomerulonephritis. He's in stage 4 chronic kidney disease, and they start him on some conservative therapy. Scary stuff, man. 35 years old. He started on these medications, so he's got that stuff to treat his anemia. He's got his hydrochlorothiazide, Catepril, some calcium carbonate. So the hydrochlorothiazide is going to treat that fluid overload. The Catepril is for his hypertension. And then the calcium carbonate is to replace lost calcium. It also binds phosphate. All right, again, we're going to talk about nutritional therapy. So we want to have good nutrition, right? We have to be careful with protein intake. Fluid restriction for the folks with hemodialysis. So it kind of depends upon how much urine output you have. They can have a sodium and potassium restriction. And then with end-stage renal disease, you have to be careful with phosphate. Okay, question. The nurse teaches a patient with chronic kidney disease about a prevention of complications. What should the nurse include in this teaching plan? Let's keep reading. Do they need to self-cath? No. So just like with their heart failure patients, we want them to do daily weights. And if they have any excessive weight gain, we want them to report that. Okay. So the answer here is D. All right, so our friend KW's condition stabilizes. He's ready for discharge. In the future, we have gone back and forth between peritoneal dialysis and hemodialysis and what he might want to do. You are responsible for knowing what hemodialysis and peritoneal dialysis are, so make sure to spend some time reading up on those. We're going to talk about him here in a second. He begins asking if kidney transplantation will cure his chronic kidney disease. And the answer is yes, it could. All right, let's talk about dialysis for a second here. So dialysis is this movement of fluid across the semipermeable membrane from one compartment to another. So it corrects the fluid imbalance, the electrolyte imbalance, and removes those nitrogenous waste products. We have two methods. We have peritoneal and hemodialysis. Make sure you know the risks and benefits of each and why one person might choose one over the other. So hemodialysis has to be done at a center. It's 3 times a week, usually like a Monday, Wednesday, Friday sort of action. So you have to have transportation to be able to get to the center. You do have to have an AV fistula inserted. It's usually in the forearm. Peritoneal dialysis can be done at home. So you don't have to travel back and forth, but you do have to be able to handle all the equipment. It can have some GI things associated with it. Oh. So you get access into the peritoneal cavity by inserting this catheter through your abdominal wall, okay? Usually it's put in via surgery, but it's done at home. You can start it right away, or they might wait till the site heals up. Very important to have a septic technique with this because that peritoneal cavity is sterile. If you introduce bacteria to it, you can get a nasty infection and get some sepsis, and then you die. So that's a real risk factor for these folks, and they already have problems with infections, right? So have to be able to have meticulous aseptic technique, okay? And if they can't, then peritoneal dialysis is not a good choice. So this is a picture of what it looks like. So that little catheter goes through the abdominal wall into that cavity. They put in the dialysis solution. It kind of hangs out in there for a while, and then it drains into that drain bag. So make sure you look up teaching for peritoneal dialysis, risk factors, complications, all those things. So again, infection is a big thing. And then peritonitis is infection of that whole space. They can get hernias, low back problems because of all this excess weight, bleeding, pulmonary complications. They can have excess protein loss. But it is more simple. It is based at home. The patient does get to be an active part. No special water systems are needed. The equipment setup is relatively straightforward. So, yeah. Let's talk about hemodialysis. So, requires rapid blood flow and access to a large blood vessel. So they put in those AV fistulas. It's in the forearm or upper arm. It allows arterial blood to flow through a vein. It's placed for 3 months before dialysis gets started. It's got to mature before you can use it. Remember, when you're assessing these guys, you feel the thrill and hear a bruit, and that has to do with how quickly that blood flow is going through that dialysis site. All right, so here's a picture. This is from your book. So risk factors, distal ischemia. So you're going to get pain to that distal access site is the main assessment finding. Numbness and tingling to the fingers and poor capillary refills. So you're going to want to educate your patient on this. If they have any pain distal to the site, if they have any numbness or tingling, that would be something that they would need to report ASAP. You can actually get aneurysms here. There is a safety alert for AV fistulas and grafts. You can't do any blood pressures, venipunctures, IV lines, anywhere ever on that arm that's affected. And we want to prevent infection and clotting to that site. So they'd have stuff posted in their room to have like a limb alert or something like that, saying, hey, don't use this. All right. So before dialysis, you want to assess fluid status, so things like weight, blood pressure, do they have any peripheral edema, heart and lung sounds. We want to see what their last post-dialysis weight was and their current weight, so we know how much fluid we need to take off. We want to assess their vascular access. We want to assess their temperature. And we're going to check vital signs every 30 to 60 minutes during the procedure to make sure that everything is going all right. For the procedure, they do use 2 large bore needles. They insert them into this fistula. One needle pulls blood from circulation into the machine, and the other one returns that cleaned off blood back to the patient. They do use heparin to prevent clotting, and there's this whole monitoring system machine that they use. It's this big thing on wheels. If you've seen one in the hospital, they're ginormous. All right. Complications. So hypotension makes sense, right? We can have decreased cardiac output, hypovolemia. So they might experience some lightheadedness, nausea, seizures, vision changes, chest pain. We would just want to be careful with how much we're taking off. And we can give IV fluids if we need to. They can have muscle cramps from decreased blood pressure, low sodium levels. So we might give IV fluids again for that. Blood loss, if they don't rinse it from the dialyzer, it can be from after they take those needles out if they bleed. So we want to just be careful with our procedure. We don't want to use too much heparin. We want to hold pressure to the access site. And then hepatitis is a risk, 8 to 10%, hepatitis C. So infection control precautions. We want to make sure that they do get their hepatitis B vaccine. We're going to talk about hepatitis in a couple weeks too. And that's it for now. I know that was kind of fast. It's lots of information, so make sure you spend some time understanding renal failure. Do use that study guide to help kind of guide where to zero in on information. And we will do a case study 72 when we meet again. I might add another case study too. I haven't decided. So yeah. All right. Well, hope you guys are doing well. and I will see you in class on Thursday.